Well, good day, good afternoon, and welcome wherever you are to this third in a series of webinars on andrology. Today's webinar is entitled Medical and Surgical Interventions in Male Infertility. This series is co-organized by the International Federation of Fertility Societies and the International Andrology Society. International Society of Andrology, I do beg your pardon. And I am joined by my co-host, Demetrius Goulas from Thessaloniki. So I would like, without further ado, to introduce our first speaker in this afternoon's webinar, Demetrius. Demetrius is the Professor of Reproductive Endocrinology at the Medical School, Aristotle University of Thessaloniki in Greece. He is the immediate past president of the International Menopause and Andropause Society, and he currently sits on the board of the International Society of Andrology. Demetrius is an expert in the field on which he's going to speak, published widely in the subject, and his talk is entitled Non-Surgical Therapies for Male Infertility. So without further ado, I'd like to invite Demetrius to speak to you this afternoon.
Thank you very much, Richard, for this nice introduction, and thank you all of you for your kind attention in this joint webinar series of the IFFS and the International Society of Andrology. So today we will deal with the management of male infertility and especially the non-surgical part of it. These are my conflict of interest. They are mainly academic. So what we will do, we will try to discuss the principles of male infertility therapy. I'll try to present and discuss with you the options available, and then we can go through the choice of the optimal therapy according to its case. Let's kick off. So the first principle is always to evaluate both partners. If this is the male and this is the female, and you can see here the reproductive capacity, let's say from 0 to 10, and the same is true for the woman, it's very improbable that Mr. A will have an intercourse with lady B. Or the opposite, actually, a male with a very serious problem to have as a partner a lady with absolutely no problems. It's very probable that there will be a degree of problem, let's say a man of reproductive capacity of 7 that will have a relationship with a lady of reproductive capacity, let's say 9, and this will make all the difference. So it's absolutely not possible to evaluate the couple if you do not know both the partners. And sometimes we do exactly this, that we concentrate, we focus only on male, on the female. The second principle I'd like to share with you is always try to make a diagnosis as etiologic as possible. Sometimes we only took care of discussing a spermiogram, and then we have something that we believe that it's a diagnosis. It's actually only a semen diagnosis, and then we proceed directly to management. If things were like this, andrology would be very easy to deal with. Just one slide. If you had a normal spermiogram, you could proceed to a natural conception. If you have a mild oligoasthenoteratozoospermia, you may go to an intrauterine insemination. A more severe problem, you would proceed to ICSI, and then in azoospermia, you have to go to TESE or to donor sperm. Sometimes we do this. And if this is not the right way, then what is the right way? Of course, what we always do in medicine. So clinical evaluation, that is history and physical examination, hormonal one, seminal one, imaging. I wouldn't think of a single case that you wouldn't do these 4 approaches, and then according to the case that you have in front of you, histology or genetic. Then you try to establish a diagnosis and then proceed to the appropriate manager. So history, I put in one slide what you should ask to every man. The female factor, as we already discussed, is very important, even in cases of male infertility. Clinical examination, this is a eugonadal David, and this is the hypogonadal David. Clinical examination, testicular palpation, sperm concentration, there is a wide variation, so it's an imperative need to proceed to a series of spermiograms in order to have a clear picture, a basic hormonal investigation, testicular ultrasound, complete with testicular triplex, especially for cases of varicocele. Transrectal ultrasound may be needed, and as we said, according to the case, cytology and histology and genetics, especially karyotype and YQ microdeletions. If you want to see that the glass is half empty, then you will realize that in about 1/3 of the cases, we do not have a clear cause of male infertility, but on the other hand, in the other 2/3, you can establish an etiological diagnosis, and once again, this is our aim. So now that we have discussed the principles of male infertility, I would proceed to discuss the available options. And according to what we have said, we have a few cases, unfortunately not more than 10-12%, that you have a clear etiology. And then you can proceed with an etiologic management. So gonadotropins, in case of Kalman syndrome, or a hypo case, dopamine agonist for prolactinoma, and appropriate medication for thyroid disease, either hyper or hypothyroidism. You have another series of cases that I would define them as oriented management. I mean, you have infections and you can give antibiotics. And of course, we will hear Peter Schlegel discussing with us all the surgical options of male infertility management. And then you have the last 1/3 that you have idiopathic male infertility, and then you can try your empirical management, not concentrated to the cause, but to the effect, which is the dyspermia. So we will discuss together in some details the SERMs, clomiphene and tamoxifen, aromatase inhibitor and antioxidants, and Manuela Simoni in a little bit will discuss with us all about gonadotropins, especially FSH. So keep in mind that in many cases, especially if you have an endocrine cause or even an infectious disease, sexual disease, erectile dysfunction, systemic disease, immunology, oncological disease, other cases, you can apply medical treatment of male infertility, and you can do so even in some cases of idiopathic male infertility. So let's proceed to the third part, which is to discuss the optimal therapy according to the case that you have in front of you. And I will follow the rationale of the European Academy of Andrology that we published in this paper some years ago. So there are three main steps: the lifestyle approach, the lifestyle management, the medical management, and then the surgical approach. There are mainly 5 main topics in lifestyle changes, 3 positive ones, so quit cigarette smoking, reduce your weight, and reduce, if it's all possible, your alcohol consumption. And the 2 negative ones are that it's not recommended to quit physical activity. Sometimes, unfortunately, this is the advice given, and there is no need, it cannot be recommended, scrotal cooling or changes in clothing or working condition. There is no evidence to support such an approach. I can give you the best evidence I can for cigarette smoking and overweight. You can understand that for lifestyle changes is very difficult, almost impossible to have clinical trials, randomized controlled trials. So all the data we have are from observational studies. And the same is true for alcohol intake, even for physical activity. Next step after lifestyle, or in combination with lifestyle, it's the medical approach. Manuela will give you all the necessary details about the FSH. She has done a lot of work with this. I will discuss with you briefly the use of antioxidants and the antiestrogens and the aromatase inhibitor. So, and of course, in any case, you must not apply androgen treatment. The only thing that you will manage to do is to inhibit the axis, so you will destroy any chance of spermatogenesis. So the use of antioxidants looks very reasonable. It looks that there is a rationale because you have oxidative stress in many procedures. You have production of oxidative substances like ROS, and this will result in sperm damage. Nowadays, we can directly quantify the oxidation by measuring these oxidation products, and we can do this in indirect way by measuring sperm DNA integrity with the famous DNA fragmentation. On the other hand, the evidence is rather inconclusive, and we have no evidence about adverse effects. If I could put on a slide the methodological problems we have with antioxidants, the results would be something like this. There is a large number, a great diversity between them. You can see some of them in the slides. So speaking about antioxidants, we always have in mind something different. Most often than not, they are used as mixtures of this, so that makes even more difficult to evaluate and to critically appraise their effects. There is a diversity, of course, in treatment duration, starting for just few weeks up to years. There is lack of indication for use. Sometimes you will read in the papers, men with infertility, and that's it. No evidence about the specific cause of infertility. The studies are non-randomized, just observational studies. And of course, different outcomes are used in some papers, seminal parameters, and some others, pregnancy rates. In parallel with the antioxidants, we have the nutraceuticals. The etymology of the word is nutrition and pharmaceutical. So these are pharmaceutical compounds that claim to have physiological benefits. According to the FDA, the American organization, they are classified in the same category as dietary supplements and food additives. So it's difficult to have clinical trials about them. I would say that they have the same limitation. Clomiphene citrate, it can be used. The rationale behind this is that it occupies the estrogen receptors in the hypothalamus and pituitary. As a consequence, the pituitary produces more endogenous FSH. Rather similar is the way of use of aromatase inhibitors. So there is a block to the aromatase enzyme from testosterone to estrogen, and as a consequence, the pituitary once again produce more endogenous FSH. The problems with them is that their effectiveness is rather controversial according to the literature, especially the aromatase inhibitor, because they reduce the amount of estrogens. They may have a negative impact on skeletal health, and for many societies are reluctant to include them in their guidelines because they are off license for male infertility. I think that Manuela will discuss in more details possible medical intervention before TESE. Nothing is working in a consistent way. And of course, Peter will discuss with us all the details about the surgical approach of medical infertility. So what we did, we discussed the principles of male infertility therapy, we discussed the available options, and then we tried to choose the optimal therapy according to the case we have in front of us. Concerning the principles, evaluate always both members of the couple, and concerning the diagnostic approach, not just a spermiogram, but use all the weapons, all the diagnostic weapons that you have nowadays. And this is a diagnostic approach in order to make an etiological diagnosis in case that this is possible. Concerning the available options, if you are lucky enough, you will apply an etiological therapy. Otherwise, you are going towards an oriented management or even an empirical one, if this is the only choice that we have. And concerning the choice of the optimal therapy, the three positive lifestyle changes, the two negative, no need to quit physical activity and perform scrotal cooling, and concerning the medical approach, antioxidants and antiandrogen, and of course, no use for androgens in order to increase testosterone and possibly help assist spermatogenesis. More often than not, that will have the opposite outcome. It's so good to have all these webinars and communicate with the whole world, but of course, still we miss them face-to-face meetings, and this is a photo from my hometown, Thessaloniki. So thank you very much for your kind attention. Thank you.
Demetrius, thank you very much for that excellent overview of the medical aspects of the treatment of male infertility. Well, moving on to our second speaker, it gives me great pleasure to introduce Peter Schlegel. Peter has recently been the Professor of Urology and Professor of Reproductive Medicine at Weill Cornell Medical College in New York, and he was chair of their urology department for almost 20 years. Peter's excellence in research and clinical practice in the treatment of male infertility has been recognized in over 350 peer-reviewed publications and has been recognized by awards from several august bodies in the field. He is a former president of the American Society for Reproductive Medicine, the Society for Male Reproduction and Urology, the Society for Reproductive Surgeons, and the Society for the Study of Male Reproduction. So there is nobody more expert to give us this next talk on the surgical therapies of male infertility. So Peter, over to you.
Thank you for the opportunity to provide a presentation on surgical therapies for this IFFS seminar put together with andrology. We appreciate the International Society of Andrology's participation with IFFS in this process, bringing the male back into the equation. These are my disclosures, none of which are relevant for this presentation. I'm not going to discuss diagnostic therapies. I'm just going to focus on therapeutic interventions, particularly varicocele repair, microsurgical reconstruction. I'm not going to talk about TURED as a way of relieving obstruction, but I will talk about sperm retrieval both for obstructive azoospermia as well as non-obstructive azoospermia.
Lost sound.
It also, in the adolescent, is associated with impaired testicular growth or hypotrophy. Now, that does not mean that all men with a varicocele will have infertility, But surgical varicocelectomy should be considered in men attempting to conceive who have palpable varicoceles, infertility, and abnormal semen parameters, except for azoospermic men. And that was one of the guideline statements from the AUA and ASRM joint guideline in male infertility. Repair of palpable larger varicoceles is only required. It is not necessary to treat subclinical varicoceles. So using ultrasound to search for small varicoceles is not routinely recommended. There is an absence of definitive data for treatment of varicocele in men who are azoospermic. That was also a guideline statement from AUA and ASRM. It's also presumed that the female has normal fertility or potentially correctable infertility before fixing a varicocele. When a varicocele is repaired, improved semen parameters are routine, and pregnancy typically occurs without any other intervention for at least 40% of couples in the first year and 70% of couples within 2 years. There is clear, controlled data in multiple trials that demonstrates that varicocele repair improves pregnancy rates, and varicocele repair also can improve sperm quality, including sperm DNA fragmentation, that may be a benefit before ICSI treatment. In obstructive azoospermia, there is always a balance between considering sperm retrieval with assisted reproductive technology versus microsurgical reconstruction. Sperm retrieval in obstructive azoospermia is relatively straightforward because sperm are routinely present in the testis, epididymis, or vas deferens if the vas is present. So a whole series of different techniques can be used for sperm retrieval. Sperm retrieval from more distal areas of the reproductive system may gather sperm that have increased sperm DNA fragmentation, and this should be considered. Microsurgical reconstruction, for example with a vasovasostomy, as is shown here, can be carefully and precisely performed using microsurgical techniques. Even when the obstruction is in the epididymis, 2-suture or 3-suture microsurgical vasoepididymostomy, although technically challenging, is a very feasible procedure to reconstruct these obstructions and allow natural pregnancy with no other intervention. Sperm can also be retrieved for cryopreservation during these microsurgical reconstruction techniques, providing an added benefit for couples. After vasovasostomy alone, overall patency rate is 85 to 90%, and overall pregnancy rate is 50%. It is clearly a more cost-effective procedure and has a higher pregnancy rate relative to sperm retrieval ICSI at the routine centers. Low risk, appropriate treatment for men desiring fertility after vasectomy is vasectomy reversal. These data overview what we see in terms of the relationship between obstructive interval and pregnancy rate after vasovasostomy alone, and this doesn't consider the additional pregnancy chance that can occur with vasoepididymostomy. The cost per delivery is dramatically different after reconstruction. It is much cheaper and more efficient than proceeding with assisted reproduction. But female factors should be considered both with vasectomy reversal and also with assisted reproduction, obviously. So pregnancy rates and live birth rates tend to decline as women get older, particularly for women who are over 40. Some consideration for assisted reproduction in an earlier intervention should be provided. Non-obstructive azoospermia is a much more complex situation. This is a condition of severely impaired sperm production so poor that no sperm reach the ejaculate. It is a frustrating condition for both providers and patients because many men cannot be successfully treated with current interventions, and medical treatments quote unquote, a magic pill has been elusive. No medical treatments reliably improve men's fertility in non-obstructive azoospermia. Again, this is a difficult condition. This is a view of a testis from a man with non-obstructive azoospermia. The testis is only 1.5 centimeter in length, whereas a normal testis is more than 4.5 centimeters in length. But even though abnormal production is present by definition, there tends to be heterogeneity of sperm production. So even though production is so low that no sperm reach the ejaculate, there are 500 or sometimes more seminiferous tubules within the testis, each of which work independently, and only a single focus of production is necessary to be able to retrieve sperm from the testis and use it for ICSI. Now, the initial approach to sperm retrieval that was used in this sitting was to use a simple testis biopsy. But when testis biopsy fails, as demonstrated in this patient, there can be problems. So this is a patient who had 2 sperm retrievals, successful one, and then an unsuccessful one done too early afterwards. In this transverse scrotal view, you can see that the right testis has lost its blood supply because inappropriate, excessive testicular biopsies were done in an attempt to retrieve sperm. This is basically a consequence of the vessels that run underneath the surface of the tunica albuginea and can be damaged with multiple incisions in the tunica albuginea. Using an operating microscope within the testis allows us to identify those areas of the testicle where the seminiferous tubules are larger and therefore more likely to contain sperm relative to the other tissues of the testicle. And indeed, when we look at the testis itself, it has a well-defined anatomy that can be exposed by widely opening the testis, allowing dissection deep within the testicular tissue, parallel to the seminiferous tubules, parallel to the centrifugal vessels, and thereby allowing us to identify sites of sperm production regardless of where they are in the testicle. Now, a meta-analysis was done of all comparative published studies, almost 1,900 patients who were treated, comparing TESSA-FNA mapping versus conventional TESSI and conventional TESSI versus micro-TESSI. It's very clear that conventional TESSI was better than any needle approach, and micro-TESSI was 1.5-fold more successful than conventional simple biopsy TESSI in retrieving sperm. This is largely because seminiferous tubules tend to have sperm production throughout their length, as schematically shown on the left-hand side. So even though the sites of spermatogenesis are limited and the sites are not geographically predictable, when sperm production is present, it's easy to identify with a micro-TESSI approach. This is just a view schematically of what occurs during a testicular sperm extraction procedure when it is done through an operating microscope using the micro-TESSI approach. You will both see that the tissues can be opened widely and broadly examined, and that's possible when you go deep within the tissue. With some manipulation of the tissue, pushing up here with a finger, you can actually provide very, very gentle traction and go between the seminiferous tubules parallel to the testicular blood supply and thereby identify tissues deep within the testicle that have sperm production, as schematically shown here. When these tissues are removed, it's important to remember that the tissues have sperm within them. So the testicular tissue must be chopped, it must be mechanically dissected or broken up to allow any sperm within the tissue to be examined and identified. We've done sperm retrieval in over 3,000 men with non-obstructive azoospermia in conjunction with IVF for a female partner typically. We usually do sperm retrieval on the day or 2 days before egg retrieval that allows time for processing of tissue. And it also allows for injection of fresh sperm together with fresh eggs. 54% of the men overall with non-obstructive azoospermia had sperm found. 45% fertilization rate per egg injected was obtained, and a 42% clinical pregnancy rate, that is, fetal heartbeat on ultrasound, was obtained once sperm were seen. It's important to remember that testicular sperm are never normal in appearance. They do not have normal morphology, and that sperm appearance does not predict IVF outcome. Only the acquisition of motility, which is usually shaking motility, certainly not progressive motility, can affect outcome. We see a 22% pregnancy rate even when all eggs are injected with non-motile sperm. Now, it is routine, as I said before, that you will have low fertilization rates with testicular sperm, so you may have few embryos. A program for planned freeze-all may more frequently fail. You may not be able to get sperm again, and flexibility to consider, for example, day 3 embryo transfer is important if you're going to have optimal pregnancy outcomes. Who has sperm? Well, no individual parameter predicts whether a single focus of sperm production is present. For example, you look at our results, you actually see with high FSH levels, we have better sperm retrieval rates than with low FSH levels. So testicular volume FSH does not predict sperm retrieval, but the microtessi procedure is associated with fewer changes, at least as seen on ultrasound within the testicle, compared to biopsies or multiple biopsy procedures, whether we look at 3 months or 6 months. Now, certainly sperm quality can have effects on female age, and there is an interaction between the two. Sperm DNA fragmentation will decrease the chance of pregnancy, whether women are young or older, and live birth rates are significantly affected in this setting. In summary, surgical interventions can improve fertility, provide sperm for assisted reproduction. Male evaluation is important for prognosis as well as providing treatment options to couples. Obstructive azoospermia is a very treatable and correctable condition. Non-obstructive azoospermia is a more challenging diagnosis, requires coordinated treatment. Optimal sperm retrieval approaches with microtessi. Limited fertilization affects the management of these couples, but use of the operating microscope and tissue processing is critical to achieve optimal results. Microtessi is the lowest risk, most effective treatment, and multiple surgical interventions are possible for male factor.
Thank you very much, Dr. Schlegel,
I
for
thank the
this.
organizers from IFFS and the International Society of Andrology for allowing me to talk about surgical therapies.
Demetrius, over to you.
Thank you very much, Dr. Schlegel, for this excellent, very educative overview of the surgical approach to male infertility. It seems, Richard, that we have 170 participants, and this looks like a record to me. Professor Manuela Simoni trained as a clinical endocrinologist at the Unit of Endocrinology at the University of Modena in Italy, and thereafter as molecular endocrinologist at the Institute of Reproductive Medicine at the University of Münster in Germany, where she was professor of endocrinology and molecular biology of reproduction. She is currently full professor of endocrinology at the University of Modena and Reggio Emilia, director of the clinical unit at the University Hospital, and director of the Department of Medical Specialties in the same hospital. On top of this, he was working at the Institute of Physiology of Reproduction and Behavior of Noisy-le in France, having the very prestigious Marie Curie Fellow on a sabbatical leave. Her research interests are gonadotropins, androgen action, testicular function, male infertility, endocrinology, and pathophysiology of reproduction. Professor Simoni is a member of the European Academy of Andrology and the European Society of Endocrinology, and from 2017 to 2021, she was the editor-in-chief of Andrology, the official journal of both European and American societies of andrology. Manuela has working extensively on FSH as a means of treating male infertility, and exactly this is the topic she will share with us. So, Manuela, the floor is yours.
So, thank you very much. I hope you can hear me and see the presentation. Okay.
Yeah, very nice.
Very good. Thank you very much, Dimitrios, and good morning, good afternoon, and good evening to all the colleagues around the world who are following this webinar. I cannot proceed. Okay. Males, of course, contribute to male infertility, to couple infertility, and we know that couple infertility affects around 15-20% of the people around the world, and males play a role in the couple infertility in about 50% of all cases, because there is a exclusive male factor in 20% of the cases of couple infertility and combined factor in 27%. Is there a role for the male in the success of assisted reproductive technologies? We asked this question analyzing in retrospective a large number of assisted reproductive cycles, around 22,000, with our collaborating centers in Reggio Emilia, and we collected together data of over 22 cycles to see whether some conventional semen parameter could predict assisted reproductive technology success, which is not easy. Apart from the number of sperm concentration, we could observe two interesting factors. That is, if you do in vitro fertilization, then progressive sperm motility seems to play a role. And if you do intracytoplasmatic sperm injection, then normal sperm morphology seems to play a significant role, which is somehow logical if you think about the mechanism. So, is there any possibility that we can improve not only concentration and number of sperm, but also these parameters? To answer this question, I think we have to start from the analysis of the hormonal control of spermatogenesis, because we know that both FSH and LH are important to have quantitatively and qualitatively normal spermatogenesis, because FSH acts on Sertoli cell to stimulate spermatogonial proliferation and sperm maturation, and LH acts on Leydig cells to stimulate intratesticular testosterone, which is necessary for spermatogenesis. On the other hand, we know that defects affecting FSH and LH may adversely affect spermatogenesis, and the most important example of this is the hypogonadotropic hypogonadism. So, hypogonadism in general results in reduced spermatogenesis. So, we can ask the question, if this is the background, that we need gonadotropins to stimulate spermatogenesis, can we use gonadotropins to stimulate spermatogenesis? We heard from Dimitrios that gonadotropins FSH use in idiopathic infertility is empirical, but I think there is a rationale to try to do that. What is the rationale? First of all, we know from clinical experience and from the literature that if you have an hemicastration, like for instance in testicular removal after testicular cancer, this is followed by a compensatory volume increase of the remaining testes. This is because inhibin B decreases after hemicastration, which leads to an increase in FSH, and this in turn leads to proliferation of B spermatogonia. Another point deriving from clinical experience is that if you have pituitary adenomas secreting FSH, the patients in general have increased testis volume, which return to the baseline after eliminating the adenoma. On the other hand, we know that FSH treatment increases testicular volume in men. There is a couple of clinical trials in the literature who have demonstrated this. And on the experimental side, treatment with FSH of adult monkeys is capable of increasing sperm concentration and sperm number. All this data tell us that perhaps there is room for improvement of spermatogenesis, because overall this data showed that spermatogenesis does not run at its maximum in the primate. So independently of the etiology, which we don't know in cases of idiopathic infertility, people have tried to use FSH in clinical trials. And here we see a meta-analysis analyzing both natural pregnancy rate after FSH administration or pregnancy rate after assisted reproduction technology after FSH administration. And overall, the meta-analysis, based on a limited number of subjects, as you see, because clinical trials, controlled clinical trials with FSH are quite difficult and rare to perform. Overall, you see that there was an increase in pregnancy rate, both after natural conception, in terms of natural conception, and after assisted reproduction. However, the number needed to treat is very high. So in these conditions, we should treat at least 10 to 18 men to have one pregnancy more. Other investigators studied whether increasing the time of stimulation would be efficacious in improving spermatogenesis. This is because, spermatogenesis lasts around 60, 70 days. So patients should be treated at least for 3 months to see any effect. And traditionally, the treatment lasts for 3 months. Here you see in this experiment, in this placebo-controlled trials, this Ding and collaborators treated men with 3 months, but also more than 3 months. And if you keep doing the treatment, you continue the treatment for 4 months or for 5 months, the sperm count increases progressively, so that after 5 months of therapy, you have a very good improvement both in sperm count and sperm concentration, and also of motility and morphology. So perhaps the treatment with FSH should be continued for more than 3 months. The other point is dosage of FSH, because traditionally we tend to apply the dosage that we would apply to classical hypogonadotropic hypogonadism, which is around 150 units 3 times a week. Again, in this trial, you see that these scientists have used much more than 152 times a week, going up to 200 and 300. And you see that with the higher doses, there is a better result in terms of sperm count, sperm concentration, again, motility and morphology, all parameters which are very important in assisted reproduction. So in this, doing this approach, so 300 units, higher dosage and longer duration of treatment, then the number needed to treat decreases to 12 patients for natural pregnancy and 6 patients for pregnancy after assisted reproduction. This has been analyzed again in a meta-analysis some years ago, putting together all the data in the literature where more than 150 units have been used. And you see that starting from low dose, intermediate dose, and high dose, progressively there is an increase in pregnancy rate, so that the you can say, total sperm count, so that we can say that the higher the dose that we use, the better is the results that we obtain. So overall, what did we learn? What did we learn from controlled trials with FSH in male infertility? The efficacy is not very high. It is around 20-30%, depending on the trials. So we can say that FSH is not particularly effective on semen parameters at the regimens used so far, especially because, as I said before, we tend to use a substitution therapy like in hypogonotropic hypogonadism, but these patients are not hypogonadal. They are effective on pregnancy, both natural pregnancy and after assisted reproduction, but the number needed to treat is very high. There are obviously many non-responders, and we don't know why. It can be the dosage, it can be the duration, but the role of genetics needs to be further investigated. And of course, we need to investigate dose and time dependency in response to FSH. This is reflected also by the current guidelines. As you see here, these are the guidelines of the European Academy of Andrology that Demetrios has already mentioned. They suggest that FSH can be used with low evidence in men from infertile couples with normogonadotropic idiopathic oligospermia or oligospermia, in an attempt to improve quantitatively and qualitatively the outcome in terms of sperm parameters and pregnancy rate. And more or less the same is recommended by the guidelines of the Italian Society of Andrology and Sexual Medicine. In Italy, we can use FSH for the treatment of male idiopathic infertility, provided that they are normogonadotropic with FSH levels lower than 8 units per liter. And our guidelines suggest that this might lead to an improvement in sperm quantity and quality and perhaps pregnancy rate, but with low evidence, as you see here from the evidence score. Now I will briefly touch upon two other factors which can be improved by FSH treatment. That is sperm DNA fragmentation on one side and serum testosterone on the other side. This is a meta-analysis analyzing the effects of FSH treatment on sperm DNA fragmentation. First of all, sperm DNA fragmentation is increased in male factor infertility. As you can see here, a very high number of patients with infertility in which sperm DNA fragmentation has been investigated. And in general, this is the percentage of men in which you can find an increase in sperm DNA fragmentation. In this experience, they are more than 50% of men with idiopathic infertility. And here, the treatment with FSH has been demonstrated to be able to improve the sperm DNA fragmentation index. But again, this is a low number of patients, but this is what the literature provides us. The second point is serum testosterone levels. We know that this is our experience. We know that there is one subset of men with idiopathic infertility who have serum testosterone levels below the lower limit of the normal range. Here you see a study of our group with 214 patients and over 200 controls. Total testosterone is slightly but significantly reduced in infertile patients. Of course, the sperm and concentration of sperm number is reduced. Overall, around 1/4 of men with idiopathic infertility have testosterone concentration in serum below the lower limit of the normal range. These men, you see here the distribution of serum testosterone in this group of patients. You see this In these patients, testosterone is below the lower limit of the normal range, and this constitutes the Aphrodite group number 3. For those of you who have heard the previous webinar, you know that these are men with normal gonadotropin levels, oligo or zoospermia, and low testosterone levels. Now, if we look at the effects of FSH on in a group of 250 men, we can see, this is also our experience, that after FSH administration, the sperm DNA fragmentations improves and also serum testosterone improves, although these men were not treated with any LH activity, meaning or suggesting that FSH can act also paracrinally on or stimulate the secretion by the Sertoli cells of some paracrine factor that can improve also intratesticular testosterone, most probably. And in addition, of course, FSH improves sperm concentration, total sperm number, progressive motility, and normal morphology. So, in conclusion, what we can say is that sperm parameters are important for assisted reproduction technology success, that the treatment with FSH as a rational, and it may improve sperm parameters also in preparation or in the waiting list for medically assisted reproduction. That FSH improves sperm DNA fragmentation index and serum testosterone levels. However, the optimal dosage and duration of treatment are not established yet. And I thank you for your attention.
Manuela, thank you for that excellent presentation that deals with the use of FSH and its potential to improve male infertility. Our 3 speakers are now joined live in this webinar and are going to take questions through the chat, and hopefully we'll have 1 or 2. I'm just going to go through the questions as they have been posted. So the first question is from my good colleague and friend Igor Korniev. Thank you, Igor, for joining us today. And his question is to Dimitrios, thanking him for the presentation. Would you consider any hormonal stimulation before IVF ICSI to improve semen parameters of non-azoospermic men, and why? So Dimitrios, did you get that?
Yeah, thank you, Richard. Igor, there are many interventions that used before you find evidence in the literature, before IVF, or even before TESE. Just to discuss them, this is HCG. You can use human chorionic gonadotropin in an attempt to increase endogenous testosterone. You can use, as we discussed, aromatase inhibitors, clomiphene citrate, or combination. You are going to find papers on anastrozole and HCG. You can also, as you heard, use FSH, especially in cases that FSH concentrations are endogenously low, or in cases that the FSH concentration are exogenously low, because an increase in testosterone due to HCG administration. Nevertheless, I have to say, as you already heard by Peter Schlegel, that there is not a consistent way to improve spermatogenesis in men. So there is nothing that can guarantee that you will improve your chances of finding sperm or increase the possibility of having a live birth through an ART procedure. Thank you.
Thanks, Dimitrios. Peter, do you want to add to that?
Yeah, I think Dimitrios has summarized that very well. It's important to distinguish between men who have low testosterone levels, as Professor Simoni talked about, versus those who have normal testosterone levels. I think most of us would argue that with low testosterone levels, adjunctive therapy, whether with SERMs, aromatase inhibitors, or HCG, are very reasonable to normalize testosterone production. because testosterone is clearly involved with spermatogenesis. So a different approach if testosterone is normal versus those men where testosterone is low, which again, as Professor Simoni said, is relatively common in male infertility.
Igor, are you on the call, and do you want to comment on these responses? No? Okay, I'm going to go to the next question. So this is, I think, for Peter. In case of blinded biopsy, is there any higher risk of damage or fibrosis compared to TZ? I think Peter talks about that in his speech, but perhaps, Peter, you would re-emphasize that.
Sure. So scarring that occurs to the testis after an intervention is primarily related to bleeding that is left behind. Largely, one of the reasons that microtesy has such low scarring rates is that you're able to control bleeding during the procedure and limit the amount of hemorrhage that occurs within the testis afterwards. There is a stunning degree of hemorrhage, even with just needle procedures, but even simple small biopsies result in a large degree of bleeding within the testis that shows up as scar, both histologically as well as on ultrasound. So even limited blind biopsies create a fair bit of risk to the testis in our experience.
Okay, thanks, Peter. And then again for Peter, similar sort of vein, should you choose a longitudinal or transverse incision for the testis in microtesy?
So we use both equatorial incisions as well as longitudinal incisions, equatorial being usually the easiest way to get full exposure. There are some concepts that people have proposed recently that you actually see more of the testis with a longitudinal incision. Our concern with routine use of longitudinal incisions is they often will cut through more vessels under the surface of the testis, potentially creating risk. So limited number of patients where we see that the blood vessels are running in a longitudinal pattern, we will use a longitudinal incision. More commonly, we use a transverse or equatorial incision.
Okay, thanks, Peter. I've got a number of other questions. We're going to run out of time, but we'll plow on until we get cut off. Where are we now? Do you perform any treatment pre-microtesy for non-obstructive azoospermia, including Klinefelter syndrome? I think that was picked up, but Peter, perhaps you could speak to that.
Sure. Again, if the testosterone, serum testosterone is low, yes, we recommend medical therapy. Our experience and overall data for men who have normal testosterone levels is that we don't increase the sperm retrieval rate by any sort of medical therapy. There are a handful of studies where repeat TESI is done associated with an increased sperm retrieval rate after medical therapy. Unfortunately, those studies are not controlled for just a repeat TESI versus repeat TESI after medical therapy. So we don't see good evidence to do medical therapy if your testosterone is normal.
Okay, I'm going to try to get one more in, and again, it's to Peter. I'm just taking them in order. My question is about indications for varicocele treatment for men with infertile couples, having in mind that neither varicocele itself nor semen parameters below 5th centile should be considered the male infertility direct causes. There must be a risk of overtreatment of patients with varicocele and oligoacinoteratozoospermia. No evidence surgery results in improvement in live birth rates. Some have drawn opposite conclusions that this kind of surgery may decrease male fertility. Could you please comment?
Sure.
Area.
So I think all of us would agree that semen parameters are not a perfect predictor or even necessarily a very good predictor of male fertility potential. It's certainly one way that we can identify where a male factor may be present. If we look at men who have clinical varicoceles, abnormal semen parameters, and infertility. Meta-analyses provide us pretty strong information. Even the Cochrane meta-analysis shows strong evidence that you actually do improve fertility with varicocele repair in that setting. And that, of course, is when we most strongly consider it.
Okay, thanks, Peter. The webinar is officially out of time. I would like to take this opportunity, along with my co-chair Demetrios, to thank our participants in this webinar today, both our guests who've joined us, but principally our three fantastic speakers who've given great talks on the areas that they've been asked to address. I'd like to also thank the sponsors of this webinar series, Merck, for their unrestricted educational grant in supporting this series. And I'd like to draw your attention to the fact that the contents that were presented today by our three speakers will be on the IFFS website for you to access. And we will also invite our three participants to address the questions that I've not been able to get round to in the Q&A. And they can perhaps post online responses to those questions. So with that, and once again, thank you to our speakers, our sponsor, and to all of you who've joined this webinar this afternoon. It's been a great session. Thank you all for joining us. Thank you and good day. Thanks, Peter.
Thanks, Richard. Well done.
Good for joining us.
Thank you.
Well,
Bye-bye.
Demetrios and Manuela,
Secretary,
thank you very much for your contribution today. I didn't have time to have a chat, but thank you for coming along. And Demetrios, likewise, thank you for being present at this seminar. Great.
Great.
Bye-bye.
Okay, I'm going to close the session now. Thank you all.
Thanks.